Hello, everyone. Good afternoon.
Good afternoon, Doc.
May we start this afternoon's Decury discussion already? For today's discussion, we will be having our individual POMR. And as a reminder, as per usual, we are going to try and make our discussion as interactive as possible today. And may I also remind you that you have some pending pluses from your original discussion a few weeks ago. And I am glad to say that I'm very proud and very happy regarding the outcome of your outputs today, individual as well as group. So, in fact, if I would say so myself, it seems as though it's in the level of someone who's in maybe advanced studies in medicine, maybe already at the internship level. So take note, hindi clerkship, ano, internship. Ang galing-galing. I'm so happy. So congratulations. I'm tempted to give all of you a perfect score. Sana. But of course, mahirap naman bigyan kayo lahat ng perfect kasi parang there's no more room for improvement. But definitely, I feel that you have expended a lot of effort, a lot of time. You've read your references and also you took a lot from the lesson that we had already prior. So if just as an additional guide for you for our criteria today, aside from the original competency required for you, that we are now going to include the output problem list as another scoring criteria. So in fact, your problem list will account for 4 points, and today's attendance and discussion, which I know we have problem with, is worth 6 points. So that's a total of 50 points already. So in the case of your group, I am fairly positive that this will pull up your grades. Like I said, almost a perfect performance. So congratulations, and a huge pat on the back for all of you guys. Thank you very much. So as a reminder again, 'di ba sabi natin for our problem list formulation, I am glad that in fact all of you stuck to our guidelines that we gave last time. Ang dami nating na reveal na hidden problems for our patients. So I am glad that you are also using not only your stock memory but also your recent memory from this last lecture. So yes, happy naman tayo, and I will make myself the broken record for today again in saying that our diagnosis is only as good as our database. And in doing that, you have excelled in this exercise, as well as your plan being based on your assessment. So still the magical key points of the day. So the next slide will be your actual problem list.
Christian po, Doc. So for the problem list, for the problem list number one, I have listed circumoral cyanosis associated with cough, coryza, and fever, and poor feeding. For the approximate date of onset, sneezing started on May 7, 2020, while colds May 8, 2020, fever, cough, and poor feeding May 9, 2020, and cyanosis on the day of admission, uh, May 11, 2020. The date recorded, it's 5/11/2020. The status is active.
Kristan,
Yes po,
siguro
Doc.
ang iko-comment ko lang dito sa problem number one natin, ano, tanggalin na lang siguro natin itong word na associated with. So sabihin na lang nating the circumoral cyanosis, comma, cough. Moving on to the next slide. Go ahead.
For problem number two, I have listed facial rashes on the left cheek and scaly lesions on scalp. Approximate date of onset was not given, and the date recorded 5/11/2020. The status is active. On problem number three, it's nasal secretion every morning. The approximate date of onset is not given as well. Date recorded 5/11, and status is not indicated. So for the incidental findings is the positive transillumination. Status is active, and as well as flat bluish to purplish lesion on the sacral area. The status is inactive as well. However, there's a poor the low length for age, height, weight for length, and BMI for age 5'11", which is active.
So, I would say pareho lang naman tayo ng ating problem list. Kaya we'll move on to the subjective basis.
For the subjective basis of our first problem, the patient is 1 month and 10 days old male infant residing in Baguio City. This is the first admission of the patient in the institution with the chief solution is allergic to tuberculosis, and the patient presented with sneezing that lasted for 4 days. On the fourth day, prior to admission, uh, the sneezing happened mostly during the morning and ceased in the afternoon. The sneezing was then followed by colds of 3 days duration. The patient also had associated greenish to yellow discharge. And 1 day prior to admission, the patient was given nasal drops with which gave short relief to the symptoms. There was also associated productive cough of 2 days duration and undocumented fever, which was managed by a sponge bath 2 days prior to admission. And there was short relief with administration of paracetamol drops, 1 day PTA. And then a few hours PTA, the fever was unrelieved by paracetamol. The patient also had poor oral intake for 2 days. This was also exemplified by distress during feeding via crying, and the patient also took quick breaths in between latching during feeding. And few hours prior to admission, the mother gave the patient Broxol drops. The patient has no recent hospitalizations, and I'm sorry, my mistake here. The immunizations are complete for the patient's age according
Okay.
to
According to?
the immunization schedule.
All right.
Yes.
Okay, sige. Go ahead.
This is not supposed to be here. I'm sorry. Next is the patient's maternal grandmother is also sick currently with cough and fever, and the patient lives with his family in a bungalow type house. So the household, there seems to be householding because they're a big family. So there's exposure to the sick family member as well. And then there's also environmental exposure to the chemicals since the mother brings the patient to the automotive repair shop that they own. For the review of systems, there was positive incessant crying, irritability, and poor oral intake. And for the HENP, the patient was positive for cold, sneezing, nasal stuffiness, and cyanosis. There was also positive productive cough and fast breathing, and the patient also has disturbed sleep.
Lian, what type of medication is Nasatap?
To treat nasal congestion po.
Specifically, what are the components? It's more like decongestant at saka antihistamine. So usually those
Okay.
decongestant drops are either brompheniramine or phenylpropanolamine or phenylephrine, more on the lines of that one. So as a reminder again for you and your group mates, and when you're already in your clerkship rotation, it's actually better to look up your drug directories. So what is the thing with Nisatap and all of these other decongestants? Actually, they are not advised to be used sana in very young patients. So there's a little bit of reservation. So unless the patient is really, really congested, we usually prescribe it, yes. Pero if pwedeng decongest via saline solution or saline nose drops, that would have been better. Okay. So thank you,
Okay
Lian.
po.
Maybe I can
Noted
ask
po.
Johnny naman this time. Johnny, do you think that which was 0.5 ml is appropriate? No. Oh, why is that? Sasabihan ka pa sana ng clue eh.
Ay, sorry po daw.
According to our physical examination, the current weight is 4.5 kilograms. So ang sagot mo ay no, hindi siya appropriate for age or weight. Ang clue natin is binibigay ang paracetamol na drops to young age patients, especially babies or neonates or infants. At ang consistency formulation niya is 100 milligrams per ml. So at this point, ang binibigay natin ay 50 milligram kasi 0.5 ml lang. Do you remember our last discussion in the POMR group na sinabi natin what is the ideal dose for control of fever in paracetamol in milligram per kilogram per dose? So learning point natin ulit today, it's actually 5 to 10. We usually use the 10 and recently we've changed that to 10 to 15. So appropriate siya for age kasi halos kung 0.5 para siyang nasa 10 milligrams per kilo per dose. So, sa tingin ko, this is tama. Hindi rather questionable, ano? So, yung ating issue ng, patient is having persistent, undocumented, on and off fever, not because of a wrongly dosed paracetamol, because as per our reference here, which is the protocol, is okay naman ang dosing. Okay. So next question, I'll be asking, anong
Yes po.
klase ng medicines you use?
Ambroxol po.
Anong klaseng
Mucolytic
meds ang Ambrox?
po siya.
Mucolytic. Okay. So again, is it appropriate to be given for this age?
Since
1 month
may
pa
ano
lang
po
siya.
siya, I want more.
Parang wala, kahit na pick up consensus, 'di ba? I don't
Opo.
think na meron tayo na nabasa doon na nagsasabing kailangang magbigay ng Ambroxol. So again, if you
Mm,
noticed, comment lang, the patient's mother believes in the power of public opinion.
true.
So
Ay,
friend,
nakawala
kaya
po.
medyo mapaniwalain sa mga bagay-bagay ng popular opinion. Kung sinabi ni kapitbahay, ibigay niyo ang medicine na ito, yun ang ibibigay ni mommy. So yun ang napansin natin, ano?
Opo.
Anyhow, so yes, maganda naman, I would say dagdag na rin natin dito sa subjective basis natin yung unremarkable prenatal and natal histories, 'di ba? So kasi puwedeng consideration pa rin natin ang neonatal pneumonia vis-a-vis pediatric community-acquired pneumonia. So may difference in etiologies yan. So when we say that there's an unremarkable prenatal and natal and postnatal histories, hindi na tayo maghahanap pa ng etiology during the neonatal period. Ganun. Okay, all right. So moving on.
Objective basis, the patient was observed to be awake, irritable, febrile, in respiratory distress. The respiratory rate was 65 cycles per minute, which is tachypneic. The the oxygen saturation at room air is 90%. The patient also presented with sunken anterior fontanelle, also with alar flaring and nasal congestion, but the chest expansion is symmetrical. And he also presented with subcostal and intercostal retractions with associated diffuse rales and occasional wheezing. Most of the signs of the patient that were present upon examination are signs of respiratory distress as well as signs of possible lower respiratory tract infection.
Thank you, Lian. Is there anything else that you would like to add to this information in your physical examination that you think you missed? Tingnan lang natin ha, for a while. Meron ka bang na-miss sa palagay mo? Because I think you did. What's that? Sasabihin ko na ba ang sagot? Shall I say the answer na?
Yes po, sirit na po, Doc.
Hala, o sige, hindi bale. Actually, walang anthropometric measures doon sa
Yes, Doc.
iyong objective reasons. Parang nakalimutan ata natin. So, did you intentionally miss on this one or
Uh,
nakalimutan
um,
lang? I would say that's important kasi remember that your anthropometrics are measures of growth and development and an indirect index of malnutrition. So if you review your PCAP guidelines, one of the comorbidities that will worsen the prognosis and course of pneumonias is malnutrition. So let me just introduce to you the so-called WHO Anthro. So I don't know if I've mentioned this before, but it's an app and it's available for free from the website for PC systems. So hindi siya pang Android or iPhone. Pero nonetheless, it's very easy to use kasi you just input the date of visit, the date of birth, the data of the weight and the length and the head circumference on all of the other measures. And it automatically computes the standard deviations in terms of z-scores. And right here naman are your percentiles. Oops, sorry about that. All right. So, in fact, it will also produce a graph for you. Medyo tamad mode ito ng pagpa-plot. Pero kasi if you notice, dito kasi ini-enumerate niya yung eksaktong value. So, hindi lang -3 standard deviations halimbawa for weight, for length. It says less than or minus 3.24 standard deviations. So, gusto ko lang i-introduce sa inyo ito in that this app is available. Like I said, if you don't want to plot it, this one is so much easier and it will make your job so much faster when you're already in the hospital. So, let's just review for a while. So, dun sa kanyang WHO plot, automatic na ito. Sabi dito yung wait for age, ang ating pasyente is nasa 0 standard deviations. Kung ipo-plot natin manually, here's the actual is in the normal range. For the length, for age naman, dito tayo nagkakatalo. So, ang hirap kasing makita sa plot, kung minus 2 standard deviations ba siya or nakatapak na siya sa 3 standard deviations. So, in reality, minus 2.98 tayo. So, hindi pa siya 3 standard deviations minus. So, stunted pa rin though ang ating pasyente. At least hindi siya pumasok pa sa severely stunted. Next chart, sa body mass index, so dito rin, medyo weird. So, ang ating pasyente is actually above 1 standard deviation, which is possible risk of overweight. So guys, balikan natin yung data natin. Yung patient natin was normal in terms of the weight for age. Pero kapag titingnan ang BMI at saka weight for length, medyo off sila. At lalong-lalo na pagdating sa length for age, na talagang bagsak nga naman. So if you remember guys, anong sabi natin about length o kaya height? It is a chronic malnutrition index. So kung babalikan pa rin natin, paano Doc, kung meron pa ba tayong ibang parameters to say ang pasyente natin is maybe malnourished, pwede ba natin gamitin ang mid upper arm circumference? Sa kasamaang palad, hindi. Dahil, although the information is there, ang mga growth charts natin and references, pwede nating i-plot only at 3 months and up. So, hindi siya nakatulong masyado. Ano pa? Yung ating head circumference. So, yes, okay naman tayo dyan. So, at least, even though sunken ang fontanelles, medyo smaller ang head, hindi naman siya pumasok sa microcephaly. So, in your anthropometric assessment, we need to mention all of the following. Again, guys, tatanungin ko lang kayo, your personal opinion, pwede ba tayong magkaroon ng stunting and obesity at the same time?
Doc, nung nag-search po ako, parang may certain population po na yung pwede yung concurrent na stunted tsaka overweight po. Pero hindi ko po masyadong na-explore kung bakit. Pero parang common po kasi siya sa Asian population.
Oh, di ba? Interesting, interesting. Yes, possible yan, possible. Actually, tinanong ko rin itong information na ito kay Doktora Gomez na nagbigay ng protocol sa inyo. Siguro ang consensus na lang natin, sabi niya, sometimes there are also errors in measurement. So, especially on the part of the length, hindi naman ako maniniwala na wala siyang growth from birth until present. And then second, dun sa weight natin, although normal weight for age yan, can be affected by several factors. So how the patient is clothed, whether the patient has dehydration. So naturally, mas mababa ang weight natin kapag dehydrated siya. Pero kailangan nating i-interpret with caution ang anthropometrics natin in sick children. Siguro though, yung part ng length, yan ang talagang kailangan natin sanang tutukan. So make sure it's a proper measurement and then so that your interpretation will be proper. Okay, sige.
So for our assessment, it's acute, for my assessment po pala, it's acute lower respiratory tract infection, pediatric community acquired pneumonia, class D to consider viral etiology. Why acute? Acute because since it's less than 2 weeks in duration. So for lower respiratory tract infection, PCAP, initial symptom of URTI is followed by LRTI, which has been manifested by the patient of several bouts of sneezing 4 days prior to admission and 3 days prior to admission. The sneezing is still persistent and with colds and greenish to yellowish discharges. In the most common clinical findings or manifestation of lower respiratory tract infection are productive cough, fever, and tachypnea. And for class D, because of the following presentations, supraclavicular intercostal subcostal retraction, cyanosis, and SpO2 of less than 90%. On the next slide, it will be further be justified again. Sorry po. medyo magulo po yung ano ko. So for the viral etiology, it's common. It's the most common etiology among infants and younger children older than 1 month, but younger than 5 years of age, wherein pasok po yung pasyente. And then viral pathogens are the most prominent cause of LRTI. RSV is the most common. It is gradual in onset and associated with respiratory tract infection, which is coryza and sneezing. Fever is usually present, but temperatures are lower than in bacterial. And respiratory distress is common in infants as presented by the patient as well. Wheezes are more common in viral versus bacterial. And another factor can be grandmother has current cough and fever. ATP guidelines, why consider pneumonia? The following appeared.
Kristen, balikan lang muna
Yes, po,
natin
Doc.
yung earlier slides ano. So babalik ako
Yes,
dito
po,
sa
Doc.
slide mo ng assessment. So I guess all of you will agree, pneumonia naman talaga ang diagnosis ng ating pasyente without question. I would say pupuwede na nating tanggalin din yung part ng acute lower
Active.
respiratory tract infection. Puwede
Mm.
na tayong diretso sa PCAP. So unlike sa ORTI ano, sa ORTI kasi is medyo marami tayong levels of classification kasi medyo madaming puwedeng maging inflamed. So it can be anywhere from the nasal mucositis to a pharyngitis to a laryngitis. Pero usually kasi pagdating dito sa assessment natin, it's pretty straightforward na PCAP unless you are strongly suspicious of halimbawa bronchitis. So that's another type of lower respiratory tract infection which I believe is not really a consideration at this point. So, okey lang tanggalin natin. So, tama naman,
Yes, po,
pasok
Doc.
naman tayo.
Noted po.
Yes, thank you also. With regards your classification, yes, nailagay naman diyan at saka yung viral etiology, yes, nailagay rin natin. So, for some of you, meron kayong nilagay na in moderate respiratory distress as an additional assessment level, okay rin, puwede rin nating ilagay yun. So, remember yung diagnosis natin, sabi natin kailangan complete. So, as regards the classification, etiology, complications, and status, okay na ito as it is. So, I am glad. Okay. With regards naman dito sa ating next slide, so no problem about this. Obviously, your patient has hypoxia, 90% na SpO2, no? And of course, this one, RSV ang iyong primary consideration. So, what does
Yes, po,
RSV
Doc.
mean, Kristen?
Syncytial virus. Wait lang po, Doc. Sorry po. Respiratory syncytial virus po. Para God po ata, Doc. Sorry po.
Ayan, tama. Correct, correct. Tama siya, tama,
Ay,
tama.
tama po ba?
So, RSV, respiratory syncytial virus. So, ifa-flash ko lang saglit itong slide na ito. So, this is actually part of our PCAP guidelines. Nakalagay yan dyan. Dr. Charlene Perez, so kilala natin siya. She's a doctor in Baguio who spearheaded this research. So, sa Cordillera Administrative Region, true enough, gusto nating gawing defense ang RSV kasi strong ang evidence. In fact, for less than 1-year-old, all of those were documented to have viral community-acquired pneumonia in the hospital actually is RSV. So tingnan nyo kung gaano ka-minor yung flu na flu type na slide and you believe that your patient has RSV, this would have strongly made or confirmed your diagnosis. Pick up guidelines natin sa PATP ng 2016. Thank you for using this. Guys, kayo ba ay nagtataka rin, katulad ko, bakit kaya Dok yung
Sa
mga
5,
parameters dito sabi 3 months, 3 months to 5 years,
3
ta's
months.
dito rin 3 months to 5 years. So saan papasok yung pasyente natin? Our patient is only 1 month, 6 weeks to
1
be
month.
exact. Is it okay to use the PCAP guidelines for patients who are also outside of the 3 month to 5 years of age? So in fact, ginagamit natin ito 'no, para sa patients as old as 19 eh, ayon sa mga ibang mga pedia-pulmo. So inalam ko rin ano, yung ating mga pedia-pulmo kung ano ang kanilang sabi tungkol dito at ang sabi naman nila, yes, you can use actually the PCAP guidelines for less than 3 months. Kanya nga lang parang it was really meant to be that this parameters are 3 months and older. So for a lack of better classification system in that age group na para siyang gray zone kasi hindi siya pasok sa neonatal pneumonia. By definition, ang ating neonatal pneumonia is up until the neonatal period and extended until yung 28 days or 4 weeks. So para siyang sumabit pa sa neonatal pneumonia pero not quite. So anong gagamitin? Ito pa rin daw. So just in case may magtanong sa inyo or becomes a board exam question, strictly speaking, 3 months to 5 years old ang ating PCAP guidelines, but we extend the classification system for lack of a better classification to use. Okay, so let me just ask you again. Kristan, you can unmute your mic already.
So, for the PAPP guidelines, it appeared that it's possible, sabi po ni Doc, and then it's negative for grunting and decreased breath sounds, but all the rest are present. We can say that it's possible for pneumonia. And for the next slide will be is to be able to classify the patient as to severity, wherein at least two parameters should be present in order to classify the patient, wherein retractions of supraclavicular intercostal, subcostal is present in the patient. Cyanosis has been presented as well, and the oxygen saturation of less than 90% is also present in the patient. So, thus, it's peak up D.
If you're going to consider number 4, the general considerations, the part on the malnutrition, pwede ba nating sabihing malnutrition yung obesity? Pwede pa rin. It's a type of malnutrition, sige. But then again, sabi nga natin in terms of our classification basis, you only need 2 general entries to classify him or her into the severity grading. So, okay na ito as it is. So, we all agree in terms of PCAP guidelines, our patient is already very severe or high risk for morbidity and mortality.
So this is the overview of our basis book. So the patient's risk factors to pneumonia are first malnutrition. Malnutrition leads to immune compromise, and then we also have a primary caregiver that might be infected, and also the patient has been visiting the um, automotive station. So that's also an risk factor for pneumonia. Upon exposure to pathogen through inhalation, hematogenous or direct aspiration, the patient, the virulent pathogen would infect and proliferate in the lower respiratory tract, leading to pediatric pneumonia. So pediatric pneumonia would have would lead to two inflammatory responses, local and systemic. For the local, first, in inflammation of the lungs, there could be irritation of nearby structures. So it would present as acute abdominal pain, which can lead to incessant crying. So the local inflammatory response in the alveoli, on the other hand, would lead to two consequences. One is irritation of airways and failure of ciliary clearance, which would eventually lead to crackles and coughs and colds, nasal congestion, and sneezing. So the cough and colds, nasal congestion and sneezing would lead to disturbed sleep. And then for the accumulation of plasma exudate in alveoli would also lead to decrease in gas exchange, which will eventually lead to hypoxemia. Uh, Hypoxemia would lead to also bluish discoloration of lips and other symptoms that would be presented in the next slide. So hypoxemia would also lead to respiratory accessory muscle use and nasal flaring. So for the systemic inflammatory response, there is cytokine release. So cytokine release stimulates tachypnea, anorexia, fever, and irritability. Anorexia would eventually lead to poor suck in feeding. As you can see again, going back to the hypoxemia would lead to also tachypnea and poor suck in feeding. Poor suck in feeding would actually exacerbate the patient's current malnutrition.
Congratulations! I love
Thank
it.
you, Doc.
I like how you presented it. Siguro, kung bibigyan natin ng grade 'to, mukhang nakuha niyo exactly what we were trying to illustrate before, that it's a complete, clinical pathologic correlation. So all of the symptoms are accounted for, all of the manifestations are caused and seem to be connected by the pediatric pneumonia as an etiology. So again, huge, huge clap, isang malaking bagsak for you and for everyone. Actually, this is pretty much the basis that I saw also in your outputs. Siguro idadagdag ko na lang ano, Johnny, remember that your patient also has a background of chronic morning colds. So that can also add on to the risk factors that might be making your patient susceptible also in terms of the denudation of the nasal passages, excoriation of the mucosa there, facilitating the passage, attachment, and penetration of the pathogens, especially viruses. So at this point though, talagang viral infection din ang ating impression. Johnny, in your opinion?
Yes po, Doc.
All right. Sige. Very good, very good. So no further questions on this slide. I think we can go on to the next, which is the list of your differential diagnosis. Okay,
So
sige
for
dyan.
our differential diagnosis, we have pickup viral due to of viral etiology, of bacterial etiology, and we also have severe bronchiolitis. So these three usually have similar presenting symptoms. However, the first two symptoms written here would differentiate from one from another. So first of all, fever of 3.81 is considered as low grade. Um, it is usually common in viral pneumonia compared to bacterial pneumonia. Bacterial pneumonia usually presents with high-grade fever. Severe bronchiolitis, low-grade fever may or may not be present. The next is presence of prodromal symptoms such as sneezing, coughs, and colds, which is more common in pickup viral. The onset of symptoms in bacterial is usually and then for the factor, we have suspected infected elderly primary giver. So, Doc, dapat po baliktad yung viral tsaka bacterial. It is important to note here that RSV is a common virus among elderly. Also is a common cause of pneumonia in pediatric patient, as well as S pneumoniae. S pneumoniae is actually the most common etiology of pneumonia in elderly.
In your personal opinion, what do you think is your patient's grandma sick with? Is it a viral infection or a bacterial infection?
Doc, viral po, Doc.
Viral pa rin. So
Viral pa rin.
your grandma has a likely viral infection, probably RSV, tama?
Yes po, Doc.
But sabi mo that one of the most common in the elderlies are actually S. pneumoniae.
Yes,
Mhm.
Doc. Doc,
So,
both po sila, Doc, na
na common.
na common, Doc.
Okay, okay. Very good, very good. Well, typically in pedia, yun nga ang ating pananakit, and that's what we are teaching you. RSV is really, really, really common. But yes, it can happen in the elderly and also the immunocompromised, and especially those with underlying heart conditions or lung conditions or diabetes. And we are quite certain si grandma is probably sick with one of at maybe one or two of those lists of comorbids. So yes, tama ka naman. Tama naman tayo dyan. So yes, swak na swak tayo sa explanation. So very well explained. Okay.
So, the rest are common signs and symptoms of the three differentials.
In fact, ang hirap pag-ibahin ano. I would think that the primary differential na iko-consider ko at this point is bronchiolitis. So they're almost 90 to 95% alike, and usually it's the labs that will differentiate those two. So it's a good thing that you caught on those. And siguro ang isa-suggest ko lang ano on your next presentations, this is a nice presentation because you tabulated your main diagnosis, which is pickup virus viral vis-a-vis your two differentials, bacterial, PCAP, and severe bronchiolitis na viral. Merong mga ibang consultants will be picky who will say, differential diagnosis table na lamang ito. So you just list down your PCAP, bacterial, and severe bronchiolitis. But for me, this table works. No question, no problems, and I approve of it with 4 thumbs up.
Actually po, ang initial diagnosis ko sa patient is bronchiolitis and I cannot totally rule out pneumonia. So I considered bronchiolitis, so it is usually a clinical diagnosis. And the only differentiating diagnostic test that I would request is chest X-ray po.
So sabi ko nga just a while ago, ang hirap ipag-differentiate nung dalawa. So can you tell me before we go to the diagnostics, what was your cluing in on that diagnosis of bronchiolitis? What made you think of bronchiolitis over PCAP as a primary diagnosis?
Yung upper RTI po, followed by symptoms of respiratory distress and wheezing in a child less than 2 years of age po. Since ayun po, na-confuse din ako dun sa age ng viral cap.
Okay,
Kaya
all
I
right.
initially considered bronchiolitis po.
Okay. O sige. Siguro ang isa pa na clue na maaaring mag-contribute positively to your impression of severe bronchiolitis is actually the presence of wheezing. Mas madalas actually sa mga viral infections ng bronchiolitis yan. But not to say that PCAP viral has none. Pero
Mm.
usually mas malakas. So again,
Yes po.
tulad nga na sabi natin, if you hear hooves, think of horses, not zebras. So this being a minor consideration, I would think pupwede pa rin ang primary impression mo is yung safe, kung ano ang pinaka-common.
Mm.
So dito na tayo magre-rely in terms of statistics o kaya
Yes po.
incidences or prevalences. So we'll hear the rest of your discussion on
Sige po.
diagnosis.
Since CBC po is not that effective in distinguishing between viral and bacterial, so hindi po siya initially considered but it may be requested to check and rule out other secondary infections or complications. And chest X-ray is also not indicated in bronchiolitis since it would increase antibiotic use without benefit, but it will be requested to rule out viral cap po.
While you're transferring locations, I will just say a few things with
Sige
regards to
po.
CBC. Actually, po pwede naman may clue lang tayo no sa CBC with regards yung sabi nga nating
Opo.
differential diagnosis o kaya yung level ng leukocytosis, pwedeng clue siya. So, pwedeng hint siya to a viral and bacterial disease. But yes, you cannot distinguish between the two. So, it's only suggestive. So, you can use, there is some benefit in using your CBC, especially if you are divided or conflicted in your diagnosis. So, incidentally, Eric, I will also ask the question, perhaps for a few more bonus points for your part. What is the most common etiology of bronchiolitis?
RSV din po. Respiratory syncytial virus po. Ay,
Med
etiology daw.
tama, tama. Yes, yes, yes. Correct ang iyong
Yes
answer.
po.
Sasabihin ko lang sana hindi kasi nagbe-break up pa yung iyong audio
Ay,
ng konti. Pero nonetheless, I heard you answer RSV. So regardless, ano, mapneumonia na viral, most common RSV. Bronchiolitis na viral, RSV din. So lusot pareho.
and then chest X-ray is usually not indicated in bronchiolitis and it will increase antibiotic use without benefit, but it will be requested to rule out pneumonia. And electrolytes are no better than history and physical exam at determining degree of dehydration. So the only diagnostic test that I will request is chest X-ray in order to rule out pneumonia since it is the gold standard diagnostic test for pneumonia. So next slide po will be the expected findings between bronchiolitis and pneumonia. In bronchiolitis, it will show generalized prominence of bronchovascular markings in perihilar distribution but ay, no confluence or collapse. And in pneumonia, there will be opacity of one or more pulmonary lobes. There will be presence of air bronchograms and patchy infiltrates po. So, bale yun lang po yung ginamit ko in order to pang-support po sa
To
diagnosis
differentiate.
ko, if ever.
Okay.
Yes po.
Alright. So Eric, I think itong part kasi ng opacity of one or more of the pulmonary lobes
Yes po.
refers to a
Yes
bacterial
po.
pneumonia. So most
Opo.
likely strep or puwede pang staph siguro ito. So kasi mukhang generalized yata yung ating pneumonia
Yung finding.
diagnosis. So in fact, the patchy infiltrates, interstitial infiltrates ang makikita natin kapag viral pneumonia
Yes
ito.
po.
So, okay, sige, if kung sakali nilagay mo na lang dito sa part na ito is bacterial pneumonia, na ipagtatapat natin against bronchiolitis, yes, justified itong table na ito. So,
Yes
this
po.
is more like looking at pneumonia at a general point of view, without regard specifically for the etiology. Pero okay pa rin. So, I guess the defense here is yes, you want to do an X-ray. So, maayos naman yun. You can
Yes po.
slightly again clue into your diagnosis but none of them I mean chest x-ray is not absolutely the gold standard when it comes to
Ay, hindi po.
etiology determination. Pero gold standard siya for pneumonia. Tama ka
Yes po.
naman. Correct yun. Correct, correct, correct.
Thank you po.
Okay. So, moving on forward. So, sabi nga natin, 'di ba kulang kasi hindi pa natin alam kung ano yung etiology. Meron pa ba tayong ibang diagnostics na gustong gawin? Maybe, let's hear from Corinne ulit.
Doc, feeling dun sa microbial determination of etiology, Doc, nag-include ako ng gram stain, culture,
Mhm,
tapos nasopharyngeal swab test. Doc, yung swab is most
mhm.
likely due to the pandemic po kasi po
Tama,
suspect po siya for initial
tama,
suspect
tama.
po.
Kasi 'di ba your patient was admitted during the time na meron na tayong COVID,
Opo.
May na kaya yes, tama 'yan. So ito yung sinasabi natin i-adapt natin yung ating diagnostics on the database that we have. So alam natin yung time reference in terms of the admission. Tapos may nakita pa akong iba dito. Bukod sa chest x-ray, meron ka pang mga ibang diagnostics. Ano-ano itong mga ito? Very simple to do.
Doc, yung oxygen, pulse ox
Sa
po.
diagnostics mo, letter A,
Pulse ox po, tsaka ABG.
tama, si pulse ox. So, oxygen saturation is very important. So, monitoring at saka for management din. And yung ABG will also determine the level of the amount of oxygen or maybe pressures that you will need to apply. So, important yan for your management. Okay, so question. Corinne, how do you induce a 1-month-old patient to cough out sputum? Is it possible? So, mahirap mag-induce ng sputum kasi sasabihin mo, "Lumakak ka, iha, iho." 'Di ba parang hirap. Pero, ano sa palagay mo, Corinne, ang puwedeng gawin para mailabas niya yung kanyang plema?
Ipapasok po yung finger, Doc.
Susuka siya, susuka siya, duduwal siya, ang lalabas ay yung kanyang gatas.
Ay,
Okay. So, Korean and everyone, meron na akong i-share sa inyo. You can actually have your patients inhale or get nebulized with hypertonic saline. So, kung meron tayong 0.9 NSS or even higher, kung meron sa ospital, panebulize nyo and your patients will cough. So, actually, talagang ma-spit out nila yung phlegm. But it's not always successful all the time. So, pupwede, pero medyo mahirap gawin. Alright. The other suggestion is kapag ka ang mga patients natin ay matutulog na, mag-insert tayo ng NGT or OGT para in the morning, i-aspirate natin yung laman ng kanilang gastric contents which are usually saliva and the other components. Ang kaso dyan, syempre, with the action of gastric juices, malamang na-neutralize na or namatay na yung mga microorganisms. Usually, ginagamit yan para sa mycobacteria TB diagnosis na mas resistant sa acid. So, with regards yung microbiologic determination of etiology in terms of a specimen that's either pleural fluid o kaya sputum, medyo mahirap kunin. So, kung in-include nyo, I will give extra points because you know what to do. But in terms of the practicality of having to do this to your actual patient, medyo mahirap. And next, Corinne, sa'yo ko na rin i-derive ha, meron kang mga in-order pa na laboratories. Ano-ano ang mga ito?
CRP, PCT, yun po ba, Doc? Yung
Yes,
CRP.
tama. So, can you tell us what CRP and PCT is? Yes.
C-reactive protein, tapos yung PC.
Sa mga iba pang nagsulat ng PCT, anong kahulugan ng PCT?
Procalcitonin po, Doc.
Yun. Rian, yes. Okay. So, procalcitonin. Both the CRP and PCT are acute phase reactants. So, meaning to say po, pwede silang gamitin for the diagnosis of bacterial infections. Again, not definitive, but it will enhance your impression of the bacterial infection. So, the higher it is, the higher the chances for a bacterial etiology. Meron pa ba tayong na-miss? I think someone ordered also for chest ultrasound. Any reasons or rationale why this was ordered? Actually, nasa pickup consensus ito, kaya hindi ko kayo i-fault kung nilagay nyo ito. So, sinasabi natin na chest ultrasound can be indicated for problematic patients and those who are not responding to therapy, and more so kapag ang chest x-ray natin ay lumabas na mukha naman siyang bacterial type of pneumonia. So again, importante na alam nyo kung ano ang nasa consensus, pero dun sa write-up ninyo, kung ang isinulat nyo lamang ay yung adapted for the patient situation and financial status, okay din lang. So, meron pang isa. Yung last na diagnostic sa listahan mo, Lian, is
Rapid tests po for RSV and for COVID po.
and para-influenza
And
and
para-influenza and
rhinovirus.
rhinovirus.
Yun. So, di ba ito yung importante, guys? We're trying to establish etiologies. And one of your strongest impression is either pick up viral or kung in the case of Eric, sabi niya, pwedeng bronchiolitis na RSV. So, di ba yun yung dapat isi-screen din natin? Yan. Okay. Happy naman tayo dyan. Happy sa inyong mga diagnostics. Okay. Tapos, next, ano ang suggested na view para sa chest x-ray natin, guys? As per the consensus guidelines and for the age of the patient, the best view is PA, Johnny. So yes, tama, PA lat ang eksaktong view that we are looking for better visualization. So remember guys, ang sabi sa ating scoring criteria or rubric, dapat specific na tayo pagdating dun sa ating mga diagnostics and therapeutics. So yes, mas maganda ang sagot na chest x-ray, PA lat view. Okay. All right. So we're moving on to the management. So I guess, again, as a review, our main diagnosis is PCAP, class D, probably.
So for the management plan, based on the guidelines, we would admit the patient, and afterwards we would assess the stability within 48 to 72 hours after admission, and improvement of the following should be present. RR at full minute, resolution of tachypnea, improved oxygen saturation, body temperature, cardiac rate at full minute based on the pediatric advanced life support age-based values, and improved work of breathing. For the definitive management, if it is influenza virus, oseltamivir would be administered, and this is the dose if it is for infants 3 to 8 months, 3 milligram per kilogram per dose twice a day for 5 days. And oseltamivir or zanamivir may reduce the burden of pneumonia if it is during the flu epidemic. If it is non-influenza, antiviral drug therapy would be not uh, would not be beneficial. Instead, supportive management should be ensued. For support,
Okay. But before that, sorry. Yes, may I interrupt again? Corinne, balikan muna natin yung first slide mo. So yes, i-admit natin ang patient. Saan natin i-admit? Sa regular ward or sa ICU?
ICU po, Doc.
Tama, yes. And most especially, pick up din na tayo. In fact, at this level, kailangan na rin nating additionally refer to specialists. So, ang tinutukoy dyan sa pick up guidelines ay isang pediatric pulmonologist. So, pwede nyo lang idagdag dito, admit patient and admit to ICU with isolation precautions kung ina-entertain mo pa ang COVID, di ba? Kung i-consider natin yung inyong impression kanina. So yes, tama naman, may monitoring tayo. At with regards yung ating pediatric advanced life support age-based value, so anong target natin? Natuwa naman ako kasi ginamit mo yung term, eh. Alam niyo guys, kapag kayo ay magle-lecture o kaya gagawa ng presentation, anything you put in your presentation, you must know how to defend and support or describe. So, since nilagay mo ito, kailangan kitang tanungin.
Greater than 90% po. 92 pala,
Greater
92%.
than 90%. Ah, hmm. Okay, I would say kung pick-up guidelines ang strictly susundan natin, any value above 90% is medyo okay na. Pero, again, looking back at your slide earlier, pupuwedeng for the safe level, 95% and above. So ito yung pinag-uusapan nating difference between the 2012 and 2016 PCAP guidelines ng PAPP. So iba yung oxygen saturation na targeted natin. So medyo additional information tong pulse level, but I would say 95% is safe. Tapos ano, in terms of respiratory rate naman, meron din sa PCAP guidelines na dine-describe kung gaano kataas ang expected mo for improvement. I will leave that to you as an assignment. So dito naman tayo sa specific management natin, ano. So ang nakalagay dito is oseltamivir at saka zanamivir. I would say a word of caution sa zanamivir kasi ginagamit natin siya sa 7 years old and above. And take note, as per your description, for flu ito. So balikan natin, Corinne ha. Your patient has most likely RSV without question. Especially since sabi ko nga sa inyo, I showed you the table on the most common etiologies of viral PCAP in the Philippines, especially the Cordillera region. So I will throw back the question to you. Corinne, what if your patient is sick with RSV, not flu? Ano ang ibibigay mo sa kanyang antiviral from your readings? I think ito yata ang kulang dito sa mga output ninyo. All five of you walang mention of definitive treatment for RSV. Or maybe, meron ba kayong idea kung ano ang dapat gamitin?
Palivizumab, Doc.
Yes,
Yes po.
Eric, narinig na kita. Is Pabilisumab a generic or a brand name? At available ba siya sa Philippines?
Ay, hindi po yata, Doc.
So, balikan niyo ang mga lessons ninyo, guys, ha. Pabilisumab is used for RSV, yes, pero hindi siya considered the
Mm.
classic or gold standard treatment. It's actually inhaled, letter R.
Ribavirin.
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 Dalawa yung sumagot, hati yung score. Well, sorry, no credit. Tama, it's ribavirin. So also not available in the Philippines. And second, as much as sabi nilang gold treatment of RSV, hindi siya ginagamit lang siya sa mga severely ill patients. So in short, kung sa Pilipinas tayo nakatira, aasa tayo sa supportive measures. Okay, so
For supportive measures, conjugated vaccine against strep pneumoniae, Haemophilus B, influenza B, diphtheria, pertussis, rubiola, and varicella would be administered once the patient is of age. And removal of the tick secretions at the nasal passages would ensue by gentle suction. And for the fever, continue paracetamol every 4 hours and manage dehydration with ORS for the first 4 hours and reassess and classify and increase fluid intake and give nutritious food to manage the malnutrition.
Corinne, your patient is 1 month. Anong ibibigay mong nutritious food?
Dok, kaya general na nutritious food po yung linagay ko.
Sige na nga. O sige, so give breast milk pa rin. So nutritious, di ba? All in. The gold standard of feeding in neonates and infants. So again, adaptability of your plan depending on your specific patient is crucial. So, kailangan niyaan. So, hindi na natin sasabihing food kasi hindi naman siya kumakain. Tapos, incidentally, di ba, Corinne, remember that your patient is already admitted in the hospital with respiratory distress hypoxia, and your patient might have aspiration if you increase the fluid intake by giving ORS. So, remember, your patient is already hospitalized. So, in-hospital hydration should already be IV. So babalikan natin guys ha yung ating stages of fluid resuscitation or rehydration from our last presentation. If you remember, 'di ba, meron tayong resuscitative phase, meron tayong maintenance phase at saka replacement phase. Huwag niyong kalimutan ito po, pwede pa rin gamitin kapag your patients are dehydrated and with pneumonia. You can use this, but practice caution because your patients are probably also already having pulmonary congestion. So throwing your patient off in terms of overhydration can spell a disaster in terms of your respiratory status. So again, Corinne, your paracetamol here, I would say pwedeng sige oral pero mas preferred pa rin ang IV. So dito sa gentle suctioning natin, guys, familiar ba kayo sa Ilocano term na sultop? Sultop is the translation for
Sip,
suction.
sip.
Sip.
Sak.
Correct, correct. Siya yun. So, puwede namang gamitin ito pero meron din tayong mga suctioning instruments na available na sa ospital at meron din tayong nasal aspirator kung yan ay preferred na gamitin ng ating mga patients. Yes. So, malaking bagay in terms of relief ang ating nasal suctioning or suctioning of secretion. So, agree naman tayo dyan. So, siguro ang itatanong ko lang, Corinne, and to everyone, pagdating doon sa oxygen support natin, I don't think may na-mention tayo dito. Pasok ba siya sa either definitive o supportive? Would you classify oxygen inhalation supplemental Q2 as A, definitive, or B, supportive?
Docs, supportive po.
Supportive. Okay. Actually po pwede na siyang definitive kasi yun ang
Okay po.
pathophysiology ng ating distress or pneumonia or bronchiolitis. So hypoxemia, definitive and urgent, very urgent, I would say, ang ating oxygen inhalation. So how much oxygen are you going to administer? Again, pwede yang by nasal cannula or by facial mask. Mas mo ang pinakamaigi for this patient. Again, isipin natin ha, Tristan, tailor it to your patient.
At least 95% po, Doc.
Or from the rest of the participants and group members can answer ano ang mode of oxygen inhalation na ibibigay natin to our patient.
Mask po, Dok. Mask.
Mask. Okay. Corinne, bakit mask?
Kasi, Dok, bata po. Pag kasi po cannula, hindi po, wala po yatang
Walang.
uncomfortable po sa kanila.
Okay.
Same with anesthetics po, di ba? Kasi pag anesthetics din po is facial mask. Mask po ang ginagamit, inhalational mask.
So again, sabi nga natin, adapt to your patient. So your patient is probably going to be irritable kasi sobrang nasally congested na siya. Tapos ipapasak pa natin yung kanyang nasal cannula. Pero come to think of it, diba obligate nasal breathers sila for a good portion of their neonatal life and they're just transitioning into mouth breathing at this point. So again, it's a case-to-case basis. Usually, ang madalas namin ina-administer initially is via nasal cannula after adequate suctioning, and if hindi maiakyat ang kanyang oxygen saturation or may irritability, that's when you use your facial mask. So again, it's not in any consensus, it's not in any list, but this is more of a practical, experience-based method. Start also cheap. So again, si nasal cannula is mas mura versus si facial mask na magiging personal property na ng pasyente yan as soon as ginamit niya. Okay, I think we will have to mention also in terms of the vaccinations, good call on that one, Corinne, kasi sinabi mo, vaccines once the patient is of age. So at this point, is there any vaccine that we can give?
Wala pa po, Dok.
Next question, is there anything that we can give as a nebulization for your patient in terms of supportive management? Nebulization, useful or not? And if yes, what solution will you use? Okay, so you were considering RSV. We're talking about RSV causing wheezing. Ganun din si viral cap. So ano ang wheeze? Ano kaya ang medication na pwede nating gamitin?
Salbutamol, Doc.
Yan, okay. Thank you, Johnny.
Ayun.
Yun, sinagot na ako ni Johnny. Thank you so much. Tama, pwede tayo actually mag-administer ng salbutamol na inhaled. It can help. It can help. So again, like I said, it is not in the consensus, but right now, it's a judgment call for you if your patient is wheezing and your patient is being diagnosed or managed as a case of a viral pneumonia, po pwede. It can also increase the pulmonary or mucociliary clearance to help your patient expel the phlegm and also the debris in terms of the cellular byproducts or mucus and also sloughed off epithelium that is primarily obstructing the airways in the cases of viral cap and bronchiolitis. Okay, so I guess yun lang naman. Let me just review kung meron tayong na-miss out in terms of the therapeutics. Anyone else who would like to add on? Alam ko na. Okay. Nabanggit dito in one of your reports ang zinc. Should we or should we not use zinc in pneumonia? O sige. So, I think, I will just mention the answer kung sakaling naririnig niyo pa rin ako.
Yes po, naririnig pa.
Okay. So, the zinc can be used, but the recent consensus has changed. Before, we were advised to use the zinc for a prolonged period of time. But right now, it's divided in terms of the popular opinion. So you may or may not use it. Okay, so let's move on na to our patient education, guys.
For the patient education, avoidance of cigarette smoke and biomass fuel, specifically the automotive shop, and breastfeeding education. It's known for the patient because breastfeeding would be is known to reduce pneumonia mortality and morbidity, and also hygiene and sanitation.
Siyempre, vaccination, banggitin na natin. Although it was part of your, originally part of your supportive, actually nandito tayo sa more of patient education kasi it's already in the future tense for your patient. Ano pa, hand washing, yes. Tapos siyempre ipagamot din natin ang mga bata o matatandang may sakit in the pamilya, tama naman 'yon. And then anything else? Would you suggest also vitamins for your patient, by the way? Yes, makakatulong, pero it's not part of any consensus, but if it can help, why not? It becomes a personal judgment call. Okay. O sige. There are a lot more of supportive, or rather, patient education guidelines or advice that I saw in your write-ups. But in the interest of our not so good internet connection, yes, gets nyo naman kung ano na ang patient education natin. So, the next part is actually a discussion of the next problem entries in your problem list. And I am glad that you have made very reliable reports, comparisons, and assessments. And I don't think that we will have to discuss that portion anymore though. Pero suffice to say that I am glad with regards to your performance overall. Okay, so I guess it's time for me to say my thanks. Thank you, everyone. Short and sweet lang ang ating discussion for today. Definitely natuwa naman tayo sa inyong mga outputs. And I am, again, super appreciative and very, very glad that it turned out this way. So, before we go, are there any questions? Any points of clarifications on the things that we have discussed today?
Doc, meron po sa history ng patient, TP is equal to EP. Hindi ko po sure kung ano po yun, Doc.
Okay. So, Johnny, that refers to the anterior posterior diameter of the chest and the transverse diameter of the chest. So, if you picture it, your patient's chest looks like a barrel. So this is very typical of infants and neonates kasi at the point that if it is mas malaki yung kanilang transverse diameter, parang this happens in excessive work of breathing. So na-stretch yung sternal notch, na-stretch out yung mga intercostal areas, so it becomes very, very wide. So it's more of an anatomic consideration, but it's really not definitive of any pathology at this point. So, sinasabi lang natin common yan kapag ka nag-iiba na ang chest diameter, kapag ka severe na ang respiratory distress. Like that. Oh, so, I hope I answered your question sufficiently. Thank you again, everyone. I would like to say congratulations again to all of you. Job well done. Yay!
Thank you, Doc. Thank you
Okay.
po.
Alright. So, kung sakaling
Thank you,
meron
Doc.
kayong questions na maisip, pupuwede niyo pa rin, i-transmit via chat or email or our class stream. And, goodbye and take care.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you po.